Hello everyone. In this video, we will discuss how to approach a patient with abdominal pain, a very common disorder in OPD. At first, we have to understand what exactly the cause of abdominal pain. The most important factor to know the cause of pain is site. It may be above umbilicus, below umbilicus, around umbilicus, loin pain, or whole abdomen. So, if above umbilicus, the differentials are peptic ulcer disease, cholecystitis, acute pancreatitis, and inferior myocardial infarction. Peptic ulcer disease is usually episodic, epigastric pain, and it's related to eating, recurrent, and burning sensation is usually present. In case of cholecystitis, it is usually right hypochondriac or epigastric pain, colic in nature, radius to back or tip of shoulder, and usually Murphy's sign is positive. Acute pancreatitis pain is more after eating heavy meal, and sudden severe pain usually radiate to back. And we should always exclude inferior myocardial infarction. Below umbilicus, it may be due to cystitis or lower UTI, premenstrual syndrome, and rupture ectopic pregnancies, that is CPR. Cystitis, premenstrual syndrome, and rupture ectopic pregnancy. Around umbilicus, it is commonly in early appendicitis, constipation, and interstitial obstruction. Loin pain is due to renal or uretary colic, and in case of whole abdomen, it may be due to IBS or perforation. Depending the onset of pain, the second most important point is whether the pain is acute pain or chronic pain. In case of acute pain, it defined as pain persisting less than 3 days. In acute pain, at first, we should assess whether the patient is in shock or not. If patient is in shock, the three most important causes should kept in mind, that is rupture aortic aneurysm, ectopic pregnancy, and spleen rupture. Urgent resuscitation and surgery referral is needed in these cases. If shock is not present, then we should assess where there is signs of general peritonitis, that is muscle gardening and rebound tenderness. If signs of general peritonitis is present, so we should do chest x-ray and look for perforated viscus. We found usually fluid under the diaphragm. If general peritonitis fissures are not present, then we should look for fissures of intestinal obstruction, that is vomiting, absolute constipation, and absent bowel sound. If fissures of intestinal obstruction are present, then we should do abdominal X-ray. Dilated loops are usually present in these cases. If no fissures of intestinal obstruction, then the diagnosis should be done according to site of pain that we discussed previously. Here again the site of pain is discussed in brief. If the pain is on right hypogastrium region, that is upper abdominal pain, it may be due to acute cholecystitis, hepatitis, and cholangitis, and right lower lobe pneumonia. Pain after fatty meal is due to pancreatitis or cholecystitis. Pain, jaundice, abdominal pain, that is charcot stride, is presence of cholangitis. Murphy's sign is present in cholecystitis, and there may be presence of fever, cough, and bronchial breath sound in case of lower lobe pneumonia. If patient is in epigastric region, the most common cause is peptic ulcer disease. Pain relieved by taking food is due to duodenal ulcer, and pain worsened after taking food is due to gastrointestinal ulcer. Another cause of epigastric pain is pancreatitis and gastritis. Left upper quadrant pain mainly due to gastritis and splenic rupture. Periumbilical pain is very common in early appendicitis, gastroenteritis, and interstitial obstruction. So, severe pain out of proportion indicates mesenteric ischemia. Colicky pain, vomiting, absent bowel sound indicates interstitial obstruction. Right lower quadrant pain, that is right iliac region, is most common in acute appendicitis. Late case of acute appendicitis. Initially, it is in periumbilical region. এছাড়া ileitis, that is Crohn's ileitis, tuberculous ileitis, ectopic pregnancy, ovarian torsion, and right ureteric pain. So the key clues are migration of pain periumbilical to right lower quadrant, suggestive of acute appendicitis. We should take Ropsing sign, Soas sign, and obturator sign also, and gynecological history in case of female. Left lower quadrant pain, all are the same, the right lower quadrant pain except diverticulitis. Causes of diverticulitis should keep in mind in left iliac region. Hypogastric region, in case of hypogastric region, we should exclude acute urinary retention, cystitis, and pelvic inflammatory disease in case of female. Flank pain, that is right or left lumbar pain, renal colic, ureteric colic, and pyelonephritis. Diffuse pain, sometimes site may be difficult to identify. In this case, pain present all over the abdomen. It may be due to gastroenteritis, small bowel obstruction, mesenteric ischemia, decay, very common, and psychiatric cause. So how can we diagnose rapidly? If patient presents with pain in right upper quadrant associated with fever and jaundice, then it may be due to cholangitis. Pain in epigastric region radiate to back and raise serum lipase indicates acute pancreatitis. Periumbilical pain radiates to right lower quadrant indicates appendicitis, and pain out of proportion indicates mesenteric ischemia. Now come to the recurrent or chronic pain. Chronic pain is defined as pain more than 3 months. More than 3 months. So between 3 days to 3 months is called subacute pain. The most important is to find is there any upper or lower GIT symptoms with alarm feature. The upper GI symptoms are dysphagia, persistent vomiting, early satiety, abdominal distension, and hematemesis. And the lower GIT symptoms are rectal bleeding, palpable rectal mass, iron deficiency anemia, changing in bowel habit, and age more than 45 years. If any of the feature is present, then we should go upper GI endoscopy or colonoscopy. If upper GI symptoms are predominant, then endoscopy is done. If lower GI symptoms are predominant, then colonoscopy is done. If no alarm feature, then we will assess jaundice, abnormal liver functions, hepatomegaly, and ascites is present or not. If present, The cause of abdominal pain may be due to hepatobiliary carcinoma or chronic liver disease. If jaundice is not there, then we will look for loin pain, mass, and hematuria. If found, then we are dealing with renal cell carcinoma or ADPKD. If no loin pain, mass, or hematuria, then we should look for palpable gastric mass, weight loss, and unexplained jaundice. If present, then we are dealing with gastric carcinoma. If none of this is present, then we are dealing with most common chronic abdominal pain in OPD, that is IBS, or sometimes patient may present with endometriosis. Now, system-wise target history. When taking history, we must think beyond the abdomen and take a system-wise targeted approach. The mnemonic is GGUPAs. G for gastrointestinal system. Asks for any dysphagia and acid reflux. Is there any GI bleeding, that is hematomesis or melena? Is there any alteration of bowel habit, that is constipation and diarrhea? These symptoms point towards esophageal, gastric, or intestinal pathology. Hepatobiliary system, history of jaundice, any pale stool or pruritus. This feature suggests obstructive or hepatobiliary disease. Pancreatic, that means a history of steatorrhea, diabetes mellitus, alcohol intake. These are the red flags for acute or chronic pancreatitis. Urinary system, dysuria, flank pain. Always consider renal colic or urinary tract infection. And gynecological history in case of female. We should ask about last menstrual period, possibility of pregnancy, and any vaginal discharge. Never forget gynecological causes of abdominal pain. So the mnemonic is GGUPAs. Examination. History guides us, but examination confirms our suspicion. It should start with general examination and also systemic abdominal examination. During examinations come some quick tip, that is if patient has pain, vomiting and distension with constipation, then think about interstitial obstruction. If patient presents with pain, fever and rigidity, that is muscle guarding is present, then think about peritonitis. Provisional diagnosis is based on site, nature of pain and exam findings. Differential should be categorized according to system wise. The systems are GGUPAs, that is gastric, gynecological, urological, pancreatic and hepatobiliary, and last is vascular. Investigations. The baseline investigations are CVC. We should look for infection and anemia, liver function test, renal function test, serum amylase or lipase, and urinary routine examination. Imaging includes ultrasonography of abdomen, first line investigation, X-ray of X-ray in chest or abdomen in erect posture, and CT abdomen. And special investigation are endoscopy or colonoscopy, and sometimes ascitic fluid study. Treatment should be supportive while addressing the cause. If infection, cefuroxime may be given, tramadol for pain control, antiemetic, and proton pump inhibitor. Definitive treatment depends on the final diagnosis. This is all for today. Thank you. Thank you very much.